We'll get started. So today I'm giving a EM critical care talk, and special thank you to the critical care team, especially Dr. Choi and Dr. D'Souza. And we'll get started here. So the chief complaint, pre-hospital history notification phone rings. You have a 32-year-old female post-cardiac arrest. So the pre-hospital history, EMS gets there. You don't have family at bedside, but per EMS, the patient called out for help and collapsed. And then with EMS, when they got there, became unresponsive and pulseless. So their interventions, they started CPR, they gave epi, they got ROSC, and then they were intubated with a 7-0 tube. They became pulseless again. They got a second epi, got ROSC, and then they had pulseless VTAC. They were kind of in VT storm, so they kept going in and out of pulseless VTAC. They got 2 shocks throughout this process, as well as lidocaine, and they did get ROSC through these interventions. And then they had another episode of VTAC in the ambulance bay, and they cardioverted them because they had pulse with that one. So on arrival, the blood pressure EMS has 104/62, heart rate 125. They're bagging the patient, 100% O2, intubated, and they had an end tidal monitoring after their intubation, which was 35. So it's a little hard to see the ACR report EKG, but I'll let you guys look at it for a second. We're gonna interpret a similar EKG that we get in the ED later. So I'll just let you look at it for a minute, and then we'll all together go through one later. Hopefully you can see. And then, so for the initial assessment, airway, breathing, circulation, disability, we have airway, intubated with a 7.0 ET tube in place, 27 centimeters at the lip. Breathing, bagging, equal good chest rise, and clear breath sounds. The circulation, so they have 2+ femoral and carotid pulses, cool extremities with poor cap refill. Disability, so you have fixed dilated pupils, not responsive to verbal, physical, painful stimuli, no gag reflex or spontaneous breaths are noted. So this is the initial ED vital signs for this patient. Blood pressure 68/45, heart rate 120, respiratory rate 16 on the ventilator, SpO2 100% intubated, glucose 116, and our end tidal. So does anyone want to take a stab at the preliminary problem list that we have here? Yes. We've got shock, cardiac arrest. Yeah, so those are kind of the major issues that we have. We had a cardiac arrest with VT storm afterwards. We also have shock, hypotension, of unclear etiology at this time, although you can have some different differentials, and then severe altered mental status, so GCS of 3. So initial interventions, anyone want to throw out ideas of things you would start to do for resuscitation for this patient? IVO2 monitor, yeah.
See it, that heart rate actually, is it hyperdynamic and fluid responsive, or I would do a chest X-ray for cardiogenic shock. Call for chest X-ray.
Yeah, it takes a little longer for them to get there. Yeah. So for initial interventions, you do under your IVO2 end tidal monitor, mechanical ventilation. These are the initial settings. Medications. So it started with fluids, as someone said, just to kind of help with the hemodynamics and blood pressure. Started peripheral levofed as well at the same time. And then continued with lidocaine. They had given that as their initial antiarrhythmic agent. This patient's in VT storm, so you want to prevent further arrhythmias. Usually amiodarone most people start with, but EMS started with lidocaine, so we just continued that. And then in terms of any testing, just the initial resuscitative testing, you're going to do EKG, POCUS, and we did order the chest X-ray. It does take them a little longer to come down, even if you overhead. So general physical exam you're doing at the same time as this resuscitation. You have a patient who is intubated, non-responsive, ill-appearing, fixed and dilated pupils, atraumatic head, and then ET tube is in place. Cardiovascular, tachycardic, 2+ radial and femoral pulses. It feels regular, delayed cap refill. The abdomen is non-distended. There's an XLAP scar as well, and non-tender, but you can't really assess that in this patient. Extremities, so dry with cool fingertips, no rashes, bruising, no lower extremity edema. And then our neuromuscular exam, which we already talked about, no real changes to that. They're not moving, and then not really showing any signs of brain activity. So this is our first EKG that we did in the emergency room. Does anyone want to interpret this? Kind of going through, you know, the way we usually will interpret together. So are we sinus rhythm? Yeah, so it looks like sinus, especially in some of the leads, it's easier to see the P waves. Yeah, so we have a normal axis. Yeah. So does everyone see what Shane's talking about? And then how do the intervals look to you?
Like a little bit prolonged. QT.
Yeah. We thought so too. The EKG calculator also thought so. So it looks like more than, half of the R to R. And then the EKG, like AI also calculated around like 513. The rate is around like 100 as well. And yeah, that's pretty much the major things. All the other intervals look okay too. At that point, we gave magnesium, like 4 grams, just given that you have someone with a arrhythmia and prolonged QTC. We did some other things too, but I'll save that for later. And then bedside ultrasound, I tried really hard to find it from downstate. It was lost into the ether. So it was a decreased, globally reduced EF. There was no pericardial effusion, no D sign. Valves in the chambers were grossly normal. And so differential diagnosis. Does anyone have some things that they're thinking about? Just like 1 to 2 differentials or 2 to 3. You say MI? Yeah. Mhm.
She had a history of a stroke in the past.
Yeah. Yeah. And then in terms of like things that point of all of those things are things that we were thinking about, especially this like acute onset of this arrest. PE a little less just because there was no D sign, there were no hypoxia, but you could obviously still have a massive PE. And if she had stroke before, has probably risk factors for it. This is just initial differential I kind of put up there. So MI, stroke, and then also malignant ventricular tachydysrhythmia. So like Esteban was mentioning toxic, there can be lots of different things that can cause VTAC. Maybe she had a prolonged QTC and was taking certain medications. But with that initial EKG as well, we we'll wait and see what we did. But in terms of reassessment, so after your initial interventions, the hemodynamics are improved, blood pressure is okay, heart rate has come down a bit. And then in terms of further testing and considerations, so we did call code STEMI, just given the fact that this was an acute onset of arrest, multiple rounds of VTAC, and then that EKG did show this elevation in AVR with diffuse ST depressions. We'll talk later about that EKG and the differential you should have for it. But given no other real history, it was high on our differential to have an MI, so we wanted cardiology coming down quickly and potentially opening the cath lab. And then these are the labs we got. Makes sense to obviously get electrolytes and then troponins, BNP for the cardiac function, BBG, see how bad the acidosis is, and then pre-op stuff in case, they are going to cath lab or other interventions. And then the imaging still pending, chest x-ray, and eventually trying to get a CT when they're more stable. So code SEMI was called. Initially, the cardiology fellow was also concerned like we were. They were, trying to activate the cath lab, getting things ready, talking to their attending. The attending came down. He was less impressed. He didn't really feel like this would be a STEMI. He said it actually maybe seems more like subendocardial ischemia, which we'll talk about later. So we're having this discussion with cardiology at the same time. With that repeating the EKG, does anyone want to compare this EKG to the last one? Yeah. And then just, so that's exactly right. Like it's showing an improving EKG. This is the prior one. So you can see that the ST depressions are, have reduced a lot. The ST elevation even in AVR is improved. And then the bedside echo also showed that the EF was improving as well. So at this point, you're kind of pointing away from MI and maybe more likely what the cardiology attending was saying, which is that this is likely more from subendocardial ischemia that we're seeing this pattern, especially now that everything is improving with the hemodynamics improving. And then additionally, we're getting some more medical history here at the same time and talking to family over the phone, getting collateral. So all these things are kind of happening at the same time to kind of reach the same conclusion. Through chart review, this is the patient's medical history. So the number one problem that they've had is that they have this large posterior fossa AVM. They've had multiple previous ruptures that was complicated by like an obstructive hydrocephalus, needing a VP shunt in the past, embolized multiple times, 2017, 22, 2018. I'm not going to read all the different vascular structures that go into this AVM, but it involves like many of their posterior circulation. So basically it's too dangerous to go in and surgically remove. And then they plan for another embolization the following month after this presentation as well with neurosurgery. They also have hypertension and then history of bowel perforation, status secondary to a VP shunt getting infected with multiple abdominal surgeries, including an XLAP, anxiety, depression, and then those are their home medications. So this is from the social worker note, just keeping in mind social determinants of health. So they have food insecurity, they're from financial concerns and were unemployed, but all pretty much secondary to the deficits that they had from all this history of multiple prior strokes. They had lost almost all their eyesight, their balance is very poor, they couldn't go out on their own. They now were sharing an apartment with their aunt. Previously it was in the shelter and then suffered a lot of anxiety and depression just from all of these medical problems that they've been going through. So additional history, called the aunt, and she said that basically the patient was in the other room, called out, found her on the ground and said, "Help, I feel like I'm having another stroke. I can't hear out of my right ear." And then the aunt said there was also like some Tylenol in the bathroom, so maybe they had had a headache, but otherwise were in their normal prior state of health. Talked about goals of care. They had never talked about, intubation or DNR, DNI. So the aunt didn't really know. And then also kind of explained that prognosis is very poor with that neurological exam. Just to kind of prepare the family, which I think they were prepared for, given that they were there with the through all the presentations and then for the cardiac arrest today. So for results, going through all of our lab tests, we have a VBG. Does anyone want to interpret this VBG? Yeah, acidotic.
Lactic.
Yes. Yeah, so mixed lactic respiratory acidosis. These are the abnormal values there. CBC and coag is relatively normal. Of the comprehensive, a bicarb is a little bit low. Have some elevated LFTs. This was the chest x-ray. Didn't show anything acute, just showed the ET tube is in place. And then this is the CT head that we got. I couldn't figure out any other way to do it besides a video on my phone, so you might see me in the shadows, but. So that's like the VP shunt there. You're seeing tracing through. And that's our CT head. Oh yeah, so everyone made kind of a noise when they saw this finding, which is that there's a large posterior cerebellar hemorrhage. Basically, the CT reading shows that there is a 4 by 4.3 by 2 centimeter large area of intraparenchymal hematoma, bilateral cerebellar hemispheres extending into the subarachnoid spaces. There's severe mass effect of the ventricular system. They see loss of gray-white matter differentiation suggestive of anoxic brain injury. And then they're seeing the VP shunt as well. So our updated problem list, we have a hemorrhagic stroke, anoxic brain injury. So for that, you know, you want to be consulting neurosurgery, as well as for this hospital is at downstate, so considering transfer. And then for the mixed respiratory metabolic acidosis, increasing the tidal volume to 450 and repeating the VBG is the next step of plans. The transaminitis is likely just from decreased end organ perfusion, hypotension, now improving, really requiring like minimal peripheral pressors at this point, and cardiac arrest, continuing just with the lidocaine drip. And we now have a pretty likely explanation as to what happened here. In terms of consultations and transfer, there's a lot of discussion with the transfer center neurosurgery at the outside hospital. They were pretty much like on the phone annoyed and saying like, why are you trying to transfer this patient with like no prognosis? Which is fair considering resources, although on the phone they made sure to then later state that they were definitely not refusing the transfer. They're not allowed to do that, but they just had concerns. We discussed it with our MICU, who didn't even write a consult note. They were just like, absolutely not. We don't have a neuro ICU here. She has zero chance of any intervention or anything here, whereas at MIMO, maybe there's something. I think it's also just like your comfort level too of like, you know, having a huge brain bleed in the MICU, but no neuro ICU is just not, yeah, how they really do things there. So we did consult cardiology at this point, kind of signing off, and then the neurosurgery consult saying that you can consider transfer, but there's a very poor prognosis in this case. So just in summary of the case, the ED course, this is the repeat VBG, improvement in the resuscitation as well as the respiratory acidosis, and then the general ED course, which I just talked about. So we did transfer. This was the general summary. So you had a 32-year-old female with cardiac arrest, VT storm, status post multiple shocks, and lidocaine. Resuscitation, started peripheral levofed, lidocaine, fluids, magnesium 4 grams, and ventilation. This was the EKG with a semicode, and then it was canceled, and got collateral history and CT head showing the final diagnosis, which is a large posterior fossa hemorrhage from AVM rupture with cardiac arrest and anoxic brain injury. So sad case. There's really, I couldn't find what happened after the transfer. I talked to people at MIMO. I don't know if they saved them under a different chart or something, but they really couldn't find any iterations of the name. But, you know, from the CT and exam, like unlikely to have any meaningful recovery. So at that point, it's just goals of care with the family. In terms of we're going to move into a discussion about some of the themes from the case today. But before we do that, does anyone have any like questions about the case itself or anything we've talked about so far? Or comments? Okay. So for discussion today, we're going to talk about differential management for EKGs with ST elevations and AVR and diffuse ST depressions, as well as ventricular tachydysrhythmia. Just a brief overview of like the electrophysiology, and then talking about some of the neurologic etiologies of that. So AVR is not a lead that we usually pay too much attention to. The purpose of it is to obtain specific information from the right upper side of the heart, which none of the other leads really cover. Here, just showing you where AVR is in relation to the depolarization of the hearts the opposite way, and then it's opposite of like V4, V6, and lead 1. It covers territory not just of the right side of the heart, like the right ventricular outflow tracts, but also the basal part of the septum. And then additionally also covers endocardial surface of the left ventricle, as well as some of the apex of the heart. And it's mainly supplied by the or septal branch of the LAD or a large branch of the right coronary artery into this area, but you can have multiple blood supplies to this area. So because it covers like a large portion of the heart, in terms of cardiology and their focus on it for STEMIs, they started to focus on this lead in around like 2013, a little bit before that, because it can be helpful in diagnosis of STEMIs. Especially they started focusing on like left main or left anterior descending STEMIs. So this first study was one of the most like important ones for it. These authors basically were looking at ST elevation and then comparing it to ST elevation in V1. Their main findings were that comparing ST elevation in lead AVR and having it greater than V1 of more than 0.05 millivolts had a sensitivity and specificity of diagnosing an LMCA occlusion instead of a LAD occlusion. Although if you look at any of the other criteria, it's really not very helpful. The other thing that they found was, unsurprisingly, that it's a positive relationship between mortality and the degree of ST elevation that you have in AVR. Multiple other studies have replicated that as well, which I won't go into the findings of. But so they started to kind of think of this as a STEMI equivalent. It was even added to the 2013 American Heart Association guidelines. But there are other can't miss diagnoses, as we saw like in this case as well, that you have to consider in your differential when you have this EKG. So while it can be STEMI, it also can be other etiologies. And so this 2013 study, I think I said the other one was 2013. Those were like 2001, sorry. This one's from 2013. They looked at 133 patients with EKG, that EKG changes that we had talked about. So ST depressions in more than 7 leads, combined with elevation in AVR and V1. And 44% of those people went for a cath, but 26% of them, so almost a quarter of them, didn't have any significant coronary artery disease. And then about another quarter of them, 23%, were found to have a left main or left main equivalent coronary artery occlusion. So another study, or no, in this study, they had multiple other diagnoses. So 35% of the patients had tachydysrhythmias, 37% of them had other shock states from septic shock, hemorrhagic shock, they had dissections, PEs, and 28% of them did have some sort of occlusive coronary syndrome. And then this 2019 study also looked at asking a similar question of if it's predictive of any type of occlusive coronary artery disease to have this EKG pattern. And they found that only 10% of the patients had an occlusive OMI in their study. So they had 847 STEMIs, 12% of them had this EKG findings. 80% of them went for emergent cath, but only 10% of those people were found to have anything significant on cath. A lot of them did have severe coronary artery disease though, so showing that it's probably important for a lot of these patients to go for a non-emergent cath. And then there was a very high mortality associated with this EKG just compared to even regular STEMIs. So the first study I was talking about in people questioning whether this should be a STEMI, they proposed the term suspect circumferential subendocardial ischemia, which has now been widely adopted by cardiologists and EM doctors as well. So it's not simply thought of as a STEMI equivalent, but thinking about ischemia to the innermost layer of the heart. So the innermost layer of the heart experiences the most effects from reduced blood flow and oxygen supply. It has a higher metabolic demand, and then also gets more compressed in systole, so compression of those innermost blood vessels, which gets exacerbated by anything that's increasing your heart rate or coronary artery disease, but also in hypotension, it's the first area of the heart to experience ischemia. And then you could understand too why maybe you would have these findings in a really large vessel occlusion, like a LMCA, where a very large area of the heart is being cut off or decreased from its blood supply. So in terms of your differential for ST elevation, you want to think that something bad is happening, but then think a little bit more. So what makes sense for your patient? It can be an occlusive myocardial infarction. Like in our case, we thought that could be what's going on, given we just had a sudden arrest with this EKG pattern, as well as VTAC. But also could be, you know, just 3-vessel disease and then a state of increased demand, or non-ACS conditions completely, where you're having like supply-demand mismatch, anemia, hypoxia, any type of shock. The important things to think about too are not, you know, immediately activating cath for someone it's not appropriate. It'd be pretty devastating to send someone with some of these diagnoses up to the cath lab. And then additionally, you know, even if they didn't have some of these diagnoses or there's just 3-vessel disease, cath's not without their own complications. So it's not like a risk-free procedure as well. If you're unsure, like in our case, I think it's better to err on the side of caution and activate your cath or activate your code STEMI, and then you can always reassess the patient, get more information, and discuss with cardiology, do multiple EKGs. It doesn't mean that they're immediately going to cath lab. Before I move on to the next topic, does anyone have any questions about this EKG pattern and the management or differential?
The other differentials, ST elevations, is just what she had, was cerebellar hemorrhage.
Mm-hmm.
I've seen this multiple times, where patients come in with a really bad headache, you do an EKG, and they have these diffuse ST elevations all over the EKG. And they have no coronary artery disease, they have normal troponins, but they have cerebellar hemorrhages. So this differential of brain cardiac EKG changes and QTC prolongations is well documented in literature. It also happens in people who have seizures. So you'll see this in occasionally, rarely, thank God, in seizures, these diffuse ST elevations, and definitely in cerebellar hemorrhages.
And do you see it for like diffuse ST depressions as well as the elevation?
Yes,
Okay.
yeah, and it's wild. I mean, it's very dramatic.
Mm-hmm.
You know, everyone pulls a code H, and you do a CAT scan. They have a cerebellar hemorrhage, or they just have a seizure. But they, I think what happened in her, I don't think she had even subendocardial ischemia. I think what happened is she's one of those examples of a cerebellar hemorrhage causing QTC prolongation and defib.
Mm.
Her magnesium level and calcium level and potassium level were normal, right?
Yeah.
And it's hard to believe that she had significant hypokalemia or hypomagnesemia causing the QTC. I think this is an example of a cerebral hemorrhage affecting the heart in some way.
Mm-hmm.
Don't forget you can have both. Like sometime when emboli break off, they can split. We had a case like that just like 2 weeks ago, where one went to the heart, one went to the brain, they had both at the same time.
So just getting into a little bit of the electrophysiology of ventricular tachydysrhythmias. Cardiac, it's basically defined as cardiac arrhythmia, 3 or more consecutive complexes that originate from the ventricles. So your rate's going to be above 100. Sustained is greater than 30 seconds or requiring termination because of hemodynamic compromise. Non-sustained is 3 or more beats, but less than 30 seconds. You can have monomorphic VTAC as well as polymorphic, and then there's VFib and VFlutter as well. I'm not going to get into all of the etiologies today of ventricular tachydysrhythmias. We're going to focus, kind of good segue from what Dr. Sinnert was saying on some of the neurologic ones, but I just wanted to talk a little bit, going back to med school, don't be too scared, but of the cardiac action potential, which can kind of help us understand of why ventricular arrhythmias arise. So you have your phase 4 here, which is because your potassium channels are open and potassium's flowing out of the cell. And then the calcium and sodium start to leak in. The sodium channels start to open, voltage-gated ones, and you have your depolarization. And then those channels close, but the calcium channels remain open and the potassium continues to flow out of the cell. So you have this plateau, and then the calcium channels close and we get our rapid repolarization, and then back to phase 4 here. So this is just showing where the cardiac action potential goes in correlation to the EKG rhythm that we're seeing. With the ventricular ones, it's basically the start of depolarization is the start of the QRS complex, and then ending where finally with the T. So that QT interval is throughout this depolarization, and then we're back to phase 4 here. So the proposed mechanisms of why ventricular arrhythmias happen are enhanced automaticity, triggered activity, and reentry. Enhanced automaticity is basically just describing the state in which you're more likely to have a spontaneous depolarization. So really anything that increases sympathetic tone, which is a huge amount of factors, whether the autonomic nervous system, drugs, other things. And then the triggered activity is describing when you have 2 different types of after depolarizations that can cause arrhythmias. So early after depolarization is in phase 2 and 3, which factors that can influence this, there's a lot of different ones, but basically factors that are going to be affecting your potassium channels, so channelopathies, potassium blockers, QTC prolonging medications, because that's in that phase where you're still repolarizing, and then in the QT interval. And then delayed after depolarizations happen after the cardiac myocyte has completely repolarized, sorry. And then things that cause the delayed after depolarization are things that affect the calcium channels. So basically any type of catecholinergic surge, calcium channel mutations, digoxin toxicity, or even ischemic tissues that are more partially depolarized. Reentry is not one we're going to talk about today. It's more cardiac and etiology. It's basically a circulating waveform that depolarizes and re-excites the myocardium and circular motions. A lot of things that affect it are like anatomical obstacles, scar tissue, extra electrical pathways, or functional blocks. Focusing on the neurologic causes of VTAC here, we're going to talk about the brain and heart connection that Dr. Sinnert was referring to. It's fitting, recently it was Valentine's Day, but we're going to talk about how you could potentially have a hemorrhagic stroke leading to a cardiac arrest. So in our case, we had hemorrhagic stroke and a cardiac arrest. It's a rare complication that happens in strokes, but it can be the initial manifestation. Some retrospective analyses from both Japan and found that 7.7% of outside hospital arrests were stroke-related, and a study in Korea found that 11.4% of the outside of hospital arrests were from intracranial hemorrhage, specifically subarachnoid hemorrhage being the most predominant type. This was a study done in the Medical University of Vienna. It was a retrospective analysis of 20 years, looking at how many patients had come in from a neurological event in cardiac arrest, which was only over 20 years, 154 patients. 82% of them were outside of hospital. Most of them had PEA or asystole, but there was VFib in about 10% of the patients. Subarachnoid, again, was the main cause of this immediate cardiac arrest, but there was also intracranial hemorrhage or seizures, as mentioned, and then ischemic stroke was the least likely cause. Of these patients, 22% or 22 of them, so 14% of them were alive at 6 months, but the majority of those were people with epilepsy, not the devastating strokes that cause cardiac arrest. So it was 14 of them, which is 9% of the patients had the favorable neurologic outcome, and then 8 of those were had epileptic seizure. In terms of having ventricular arrhythmias after stroke in a more delayed setting, so not immediately, but in the days after admission, it is important to have cardiac monitoring. These patients are more likely to develop arrhythmias than just the general population. There was one study that looked at a 6-month period between May 2010 and December 2010 that had 500 stroke patients and monitored them for the first 72 hours of admission. And significant cardiac arrhythmias occurred in 25% of them, especially the highest percentage being within like the first 24 hours. Serious arrhythmias, tachycardias were more common than bradycardic ones. So tachycardia, ventricular tachycardia or supraventricular tachycardia was more common. Which shows, importance of cardiac monitoring. Most of these patients are going to be having similar risk factors for coronary artery disease because they have strokes. So a lot of it is in terms of the cardiac events that stroke patients will suffer will probably be from more like ischemic or coronary artery disease. But there is also a mechanism by which ventricular arrhythmias can happen from disruption of the autonomic nervous system and central causes in the brain. So the major explanation for how neurologic processes can lead to ventricular arrhythmias is through the disruption of the autonomic nervous system by excess sympathetic activation and reduced parasympathetic activity. It makes sense if you think back to the electrophysiology of VTAC and enhanced automaticity that we were talking about. And then additionally, it's been shown in both clinical and experimental evidence that after stroke patients do have decreased autonomic reflex impairment, as well as there's been certain studies trying to locate which areas of the brain are most crucial in playing a role in this. And specifically, they found that the insular cortex and amygdala play a role. They did some like rat studies where they simulated the insular cortex of the brain and were able to trigger arrhythmias in those rats compared to not. Or also clinical evidence of people with insular strokes or areas of the brain where the insula was also affected had a higher incidence of prolonged QT interval. In terms of the proposed like mechanism as to why this happens, one part of it is what we were just talking about, is that you have sympathetic hyperactivity from lesions in that part of the brain, as well as decreased parasympathetics. And then the other mechanism is not as immediate, but basically from your catecholaminergic surge, you have then myocardial damage, which then can predispose you to ventricular arrhythmias. They also mentioned in this paper talking about, the rare complication of getting Takotsubo, and obviously that's going to lead more likely to ventricular arrhythmias as well. It's mentioned that, from strokes, you can have increased surge response inflammation that can also lead to cardiac dysfunction. They go into like things about the gut dysbiosis, but I think this is all a little too in the weeds for emergency medicine. But it is just interesting to think about, why these patients might develop cardiac arrhythmias just primarily from brain dysregulation. In terms of seizures, overall, patients with seizures are more likely to have a higher prevalence of arrhythmias. It makes sense when you think about the etiology of a seizure. You're having an overactive sympathetic surge, tachycardia, hypertension. And then additionally, there is a proposed mechanism that patients with epilepsy, they have repeated increased sympathetics that can cause myocardial damage and then create substrates for arrhythmogenesis in the heart. Also, though, in seizures, a lot of these disorders are from epilepsy disorders are from channelopathies, which might also be channelopathies that are affecting the heart. And then a lot of anti-epileptic drugs too can do conduction blocks or QTC prolongation or other alterations. So there's kind of some confounding factors in there as well. And then in terms of other neurologic etiologies like TBI or brain mass, it's a lot less common to see ventricular arrhythmias be the initial presentation, but similar to strokes, if they affect those lesions of the brain, it's a similar mechanism by which they could cause ventricular arrhythmias. And so, you know, it's more rare presentation of a stroke. It's hopefully you're able to learn something about ventricular arrhythmias and electrophysiology and can kind of apply that beyond just stroke, but to thinking about our electrolyte imbalances or why someone maybe is in VTAC can kind of help with your management. And that is pretty much all I had for today. My summary take-home points, basically in terms of the case management itself, just the importance of having like continued conversations with consultants, you know, working with cardiology to kind of come up with the fact that we didn't think an MI was going on, working with neurosurgery as well as MICU, trying to balance, you know, people's comfortability in terms of managing a patient, and then trying to do what's right for the patient, although in this case, not much you're going to do is going to affect any outcomes. Managing AVR with ST elevations and feeling more comfortable with that EKG and trying to have a good differential when you get it. And then just appreciating, like I said, how electrophysiology could maybe help your differential or management of some of these tachydysrhythmias. Any questions? Yeah.
I'm just wondering if, knowing what you know now, if you would have done anything differently in that.
I wouldn't have done anything differently in terms of like the information that we had. You have someone with like an acute arrest, and I mean, you know, in terms of her neurological status, it could have been that she had, you know, prolonged downtime. EMS is unlikely given that she lost pulses with EMS, but you never know like how long it took them to tube or other things. And I think activating the cath lab is or calling the code STEMI, especially when you have limited information and it's high on your differential, is important. And then you can always kind of reassess and change. So.